Hello, I'm Dr. Selma Chiesa, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity titled Improving the Quality of Care for Patients with Atopic Dermatitis, Integrating Measurement-Based Tools into Your Clinical Practice. This activity is brought to you by CME Outfitters, a best-in-class accredited provider of continuing education for clinicians across the globe. 2018 is the first full year for many of you participating in the MIPS program. Part of meeting your requirements under the Quality Payment Program is participating in improvement activities. Today's program has been designed to meet those requirements. Your engagement in today's activity by answering polling questions, asking a question, and completing the evaluation and post-test are needed to complete the first step in the process. After today's program, incorporate the clinical improvements we discussed in your practice, and in 3 to 4 months, we will send you a survey to complete, which will fulfill the data collection requirement. Now, CME Outfitters will then send you confirmation of your participation, which you can submit to CMS. It's that simple. As I mentioned, I am Dr. Selma Chiesa. I'm an assistant professor in the Department of Dermatology at the University of Pennsylvania Perelman School of Medicine in Philadelphia, and I'm looking forward to our discussion today, which will focus on the role of measurement-based care in the diagnosis and management of patients with atopic dermatitis. I'm excited about our program, and we're going to share some best practices and provide some tips that any of you can integrate into your daily clinical practice. So let me introduce our distinguished faculty today. First, let me welcome Dr. John Russell. So Dr. Russell is Clinical Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University in Philadelphia. He's also Program Director of the Family Medicine Residency Program at Abington Hospital in Abington, Pennsylvania. So John, welcome.
It's great to be here today.
And also let me introduce Dr. Jonathan Silverberg. Dr. Silverberg is an Associate Professor of Dermatology, Medical Social Sciences, and Preventive Medicine at the Northwestern University Feinberg School of Medicine. He's also Director of the Northwestern Medicine Multidisciplinary Eczema Center and Director of the Contact Dermatitis Clinic at Northwestern Memorial Hospital in Chicago, Illinois. So welcome, Jonathan.
Thank you.
So thank you both for joining me today. Now, throughout this webcast, we will also be showing excerpts from a conversation about atopic dermatitis that I had with Dr. Stephen Hess. So Dr. Hess is President and Medical Director of Center City Dermatology and Clinical Associate in Dermatology at the Department of Dermatology of the University of Pennsylvania in Philadelphia. So John, as we start this conversation, can you talk a little bit to us about what are some of the challenges that we face or you face as a primary care physician with respect to caring for patients with atopic dermatitis?
Sure, atopic dermatitis is a chronic illness. We take care of lots of chronic illnesses, but I think it's one we're not doing a great job. So looking at a couple studies that looked at this question, it found that atopic dermatitis is increasing in frequency, yet the majority of patients that we're seeing have mild atopic dermatitis, but still they're being referred on and really not having much beyond minimal treatment started. So people who are doing primary care could do a better job for a chronic disease that's increasing in frequency. When they looked at this in the United Kingdom, in their national health system, they found that a large percentage of people were not meeting a diagnosis. A large percentage of people did not have any type of severity score. People who were getting topical steroids, it wasn't necessarily on par with the severity of their disease. And only about half of the patients were actually getting emollients for their atopic dermatitis. So certainly we have some learning things we need to do for our brethren.
Okay, that's great. So it's funny you mentioned, how this is a disease that seems to be increasing in the adult population. So when we look at the epidemiology of atopic dermatitis, we tend to think of this as being more a disease of children, right? But there's increasing evidence out there to support that it actually might be a very prevalent disease in the adult population as well. And the numbers vary between 3 to 10%. We think the estimates may be closer to 7%. And there's also something very interesting about adult onset atopic dermatitis. How do we characterize this entity? And it seems to occur more commonly during the third decade of life. And when you think about this being a prevalent disease, there's numbers out there showing that it could be that about every 3 patients that we see in clinic who are adult patients out of 10 might actually have adult onset atopic dermatitis. So that complicates the picture in terms of accurately diagnosing and treating these patients. And when we talk about comorbidities, can you mention a little bit about the comorbidities we may see in this patient population?
Sure, and I think when we think of comorbidities, I think we often think of atopic dermatitis and allergic rhinitis and asthma kind of traveling together in that IgE-mediated pack. But there are other comorbidities to think about, food allergies, et cetera. But there's a lot of comorbidities that are less overt. Depression. There was a study this week in JAMA Dermatology that showed over 30% of folks with atopic dermatitis have a 30% higher rate of suicide attempts. There are sleep disturbances, there are depression, anxiety, a lot of other comorbidities that aren't quite as obvious to us that we need to think about as we care for these patients.
I think that's very important. So I want to shift our focus now to the patient. So atopic dermatitis, we've discussed how this has a significant impact on our patients. So here's a video about this issue with me and Dr. Hess. So let's go to the video now. So Dr. Hess, when talking about disease burden in our patient population, what do you feel are the symptoms or the signs that most impact our patients?
Well, certainly itch. Obviously, itch is the hallmark of atopic dermatitis, and itch can be very severe. I mean, it can be unrelenting, it can be just debilitating, the itch associated with this disease. Some of my patients, though, do experience pain, and I think that can be from excoriations, from scratching the skin. And for those, especially adults with hand dermatitis, atopic dermatitis affecting the hands, many of them develop fissures or splits in the skin. That can be painful. Bleeding can be sometimes a problem also from scratching. And then related to all these things, sleep disturbance is a real issue for a lot of these patients. They're up scratching, they can't fall asleep. Sometimes the scratching will, the itching will wake them from sleep. So I think those are the, main things that I see.
So we've heard Dr. Hess' opinion, what he seems to feel is the thing that impacts the most his patients with atopic dermatitis. So John, can you comment about your experience with these patients?
Well, because so many of these are children, I think there are a lot of biopsychosocial things that they feel from that. Kids want to be the same, and kids don't want to stand out and have that rash that sets them apart. Why are they different from the rest of their teens? John, what do you see as well?
Yeah, I think what makes atopic dermatitis different than what we see with a number of other dermatologic disorders is really how heavy the burden of symptoms is compared to, let's say, the visual component. There's certainly a big stigma component, but itch being the most burdensome symptom. But I think we often don't appreciate the downstream consequences of itch, the sleep disturbances, the mental health disturbances, the pain, and everything else. So it's a complex symptomatic picture that we have to deal with.
I agree with you, and I think when we talk about children, it might be sometimes a little bit easier to diagnose and address those issues. But when you have an adult patient, I think key is in addressing those symptoms is first and foremost to make sure that we have the correct diagnosis, and so. That sets the stage for our next objective today, which is how can we apply some of this diagnostic criteria to help us establish a more correct diagnosis in clinic. And so we can use something like the Hanifin and Reicha criteria or the criteria from the American Academy of Dermatology. So John, can you comment on that?
Sure, we're going to talk about 3 different diagnostic core sets for criteria. The Hanifin and Reicha criteria looks at 3 or 4 major criteria. Pruritus, the typical morphology and distribution, like lichenification in the flexural areas, facial and extension eruption in adults, chronically relapsing dermatitis, and that personal or family history of atopy. So you have to have more than 3 of those basic features, and then there's a litany of minor features, which really talks about how pleiotropic this disease can be. And some that stand out for me is the xerosis, the keratosis pilaris, kind of the age, and kind of its presence with other IgE mediated. Any that stand out to you two about things that you're seeing for minor criteria?
Yeah, I think we see all of these really come up in different constellations, different patient subsets. I think what's an interesting just point also is in the Hanifin and Reicha criteria, how early age of onset is only a minor criteria.
Right.
And so someone can really be an adult onset atopic dermatitis and meeting all the other criteria in there.
Yeah, and I agree with Jonathan. I think that sometimes it's important when looking at the adult population that the eczema findings might not be in the more traditional area. So at least it would be useful to become familiar with the minor criteria. So, John, can you talk to us a little bit about the United Kingdom Working Party criteria?
Speaking to age, United Kingdom, though, puts it right up front.
Right.
Age, onset before the age of 2, the flexural involvement, generally dry skin, personal history of other atopic diseases and flexural dermatitis. So a simpler thing that requires more than 3 criteria. And then looking at the AAD criteria kind of combines a lot of those same type of things of itchiness, eczema, distribution, age, atopy.
And so how do you incorporated this into a basic clinical practice, right? Our audience may feel, well, I don't have time to take out a gigantic, checklist and go over all the 23 minor criteria. But I think most of us are unaware that we might even be doing this in the clinic and not be aware. So any thoughts you have on that and recommendations to incorporating this?
Yeah, most of this will come really from just a thorough history and physical exam. If you're talking to your patients and you're getting a thorough personal medical history and past medical history, family history, you're going to have a number of those criteria in terms of atopy, in terms of, you want to assess some of the basic triggers, which will touch upon the minor criterion. And then when you're doing a physical exam, know what to look for in terms of those minor criteria. I personally like using Hannafin and Rika because I think it works best in adults in terms of dealing with adult onset. The UK Working Party will actually fail, even though it's simpler, it will fail for a lot of adult onset cases because some of those are not flexural and they're later onset, and then therefore it won't work. So.
And it's pattern recognition. And I think for people who, you do that every session, you're pulling this out. I think for primary care doctors, maybe they need to downshift a little bit and just make sure if they need to open a book and look at the criteria to do that, because we're starting a road to treating a chronic illness, we should make sure we're on the right road.
Okay, and so speaking about pattern recognition, and that moves us into our next patient video, where we talk a little bit about the diagnosis in children and adults and how it's important to differentiate between the two. So Dr. Hess and I addressed this issue in one of our videos, and let's watch that now and listen to what Dr. Hess has to say on this topic. Can you briefly describe, in your practice, what sort of differences do you see in terms of atopic dermatitis between adults and children?
Well, I think the biggest difference is, in my opinion, I think it's much more difficult to diagnose adults, especially if they don't have that history of childhood atopic dermatitis. Sort of new onset, adult onset atopic dermatitis is much more challenging to diagnose. I think one of the other differences I see is distribution of where the atopic dermatitis presents. So, of course, in younger children, you see the extensor involvement, the facial involvement. And in adults, in adolescents, you see more of the flexural involvement. But I think in my adult population, I see a lot of folks with bad hand dermatitis. Eyelids are a problem. I see a lot of adults who develop eyelid dermatitis. Hand and foot, eyelids, those are the places I tend to see this much more commonly in adults. And those present, especially when we talk about eyelids, some special challenges in terms of treating those sensitive areas.
So John and Jonathan, in your experience, have you had similar observations as to what Dr. Hess has mentioned in terms of how you see your pediatric population of patients and how your adult patients present in clinic? John, would you like to comment?
So I think in the pediatric patients, I think it's a little bit easier, and oftentimes I'll think of scabies as probably that other thing I want to tuck away. I think for adults, it's really hard unless they give us the benefit of developing this disease as a child, which makes it easier for us. But I think a hand dermatitis in an adult is often a really hard diagnostic challenge for me.
What about you, Jonathan?
Absolutely. I completely agree with Dr. Hess's observations. One thing that's fascinating is for many patients who've even had it lifelong, where it was predominantly flexural, sometimes as they move into the adult years, the pattern will shift and they'll get more head and neck involvement or more hand involvement, even for those older cases, those more established cases. And that still poses a diagnostic challenge. Have they now developed a new contact dermatitis?
True.
Or is this just an evolving pattern of atopic dermatitis in adults? So I think that there's a lot of complexity in the adult population.
Okay, so now let's show our viewers some examples of atopic dermatitis. So here we have a patient, an adult patient who presents with widespread involvement. And you can see from the photograph how the lesions are not really clearly well-defined, seems to be more widespread, ill-defined. You don't know where something ends or begins. There's definitely erythema, which means redness. There's induration. And this is something that we can see not only involving just the flexural areas, like you were mentioning, more classical. In children, in adults, it can also involve the extensor surfaces as well. And then I think this is also a particular challenge that I will see in clinic is when you have patients with different skin types, right? In a patient who has, a lighter skin type, you can better appreciate the level of erythema, like for example, the picture on the right, and also the level of excoriation. However, in the picture on the left, we have a patient, skin of color, darker skin type. It's more difficult to really assess the level of inflammation. So Jonathan, do you have any comments with respect to, different skin types, darker skin types representing a challenge in terms of the diagnosis?
Yeah, so in skin of color, there are some basic challenges, which are the pigment masking that happens with, the erythema is just hard to appreciate. But there's also distinct phenotypical features that may happen, like more follicular eczema, more lichenoid papules on the hands, which can sometimes be missed because they don't look like the standard, bright red eczema that you might see. So I think it's really about that pattern recognition, getting very comfortable recognizing those different patterns in skin of color. But sometimes physical exam, it's hard to appreciate just how severe the disease is in skin of color. And I think there's a particular role for patient-reported outcomes in those patients, because the patients know how their symptoms are doing, even if we have a hard time fully appreciating just how active it is.
Right, and I think you raised a very important point in terms of the challenge of the diagnosis. And I think it's important that we also become familiar with things that can look like eczema, but are not eczema in terms of the differential diagnosis. So can you talk to us a little bit about what you think in terms of diseases that may look like eczema, and do they vary by the age of the patient?
Yeah. So a lot of our considerations will vary by age. When you're talking about an infant, we'll think about cradle cap, seborrheic dermatitis being most common. And then scabies is always a big one we have to think about. And then there are those rarer immunodeficiencies, which can actually present with garden variety looking atopic derm, but all of a sudden there's other things in the history that to think about. But when you move into childhood, those things are still considerations, but contact dermatitis starts to become more of a consideration, a lot more infections, and on occasion even pediatric psoriasis, but that's not quite as common, and of course there's other inflammatory disorders. When you get into adulthood, what gets very tricky about it is all of the differential, the entities and the differential diagnosis are much more common. So now we have to take that differential much more seriously. Certainly for head and neck dermatitis, seborrheic derm is a possibility, but contact dermatitis and T-cell lymphoma are really those big two, and psoriasis. And as much as, in the textbooks they look different, sometimes it's really hard to tell them apart in the real world.
I agree with you. I think that that's very important for us to keep in mind. And for our audience that's joining us today, this is a great resource, the table that we just shown. So we will have that for you to download in case you would like to use this for your patients. Moving on to the next photograph here, it's to your point on contact dermatitis and how that can represent a diagnostic challenge. So this is a particular patient of mine who presented with widespread atopic dermatitis, but then after having her disease under control, came back with a new eruption around the neck area, which proved to be an allergy to something that she was becoming exposed to in the form of a contact dermatitis. So I think it's important for us to remember, if you have a patient coming in, has lesions, they were well controlled for a while, but now all of a sudden they're flaring. Could it be that they've now developed a new allergy to something that they're applying on their skin? Pattern recognition, as we mentioned here before, is very important. Is it around the neck area, clearly defined, the face, or just the hands, which is a tricky diagnosis, but those are things that should raise the question that could in fact there be now a contact dermatitis that's superimposed on the atopic dermatitis. This is a picture for an audience of a patient with psoriasis, and here we can see it's also widespread disease, but the lesions are more clearly defined. It's more of a dry scale, not so much the oozing, weeping we may see in a patient with atopic dermatitis that's actively inflamed. So that's, I think, an important diagnosis also to have for our adult patients. And our next photograph is the cutaneous T-cell lymphoma, which you mentioned, that although this is not as prevalent as maybe psoriasis or atopic dermatitis, this is a diagnosis that we don't want to miss, right? Because it has implications for our patients. And some of the tricks I say, well, look for these lesions either on the buttock area, look for the lesions underneath the folds of the skin because it tends to hide from sun-exposed areas. I will also ask about B symptoms, fever, weight loss, loss of appetite, or if there's palpable lymph nodes as part of your physical exam. And here we have this is a pretty common case, again, a patient with skin of color who presents with exfoliative erythroderma. And when you see this in clinic, we need to take a step back and not just prescribe a jar of triamcinolone and let the patient be. That could be part of his treatment, but we do want to get a correct diagnosis. And this is something that could be a patient either with an acute eczema flare flare, or a patient who's has psoriasis, erythrodermic psoriasis, or even CTCL. So we have to be careful when we approach these types of patients, right? We don't want to confuse ourselves.
Could I ask you guys a question? So a lot of these cases are not intuitively obvious. Would that primary care clinician who took a little piece of it and did a punch biopsy, is that making anything worse? Does that make your job easier if I referred that patient on to you?
Would you care to answer that question?
Sure. I mean, I think it definitely helps. Keeping in mind that, as we already talked about, these are clinical diagnoses for the most part, and you really want to get comfortable in that history and physical exam of the patients. But there's definitely utility to the biopsy, at least to ruling out other disorders like T-cell lymphoma, or psoriasis, et cetera. They're not always very reliable.
No.
And from the literature, we know in the realm of inflammatory disease, they may have quite a low reliability. So, if we see a positive, so to speak, test that says T-cell lymphoma, well, that's meaningful, and we work on that assumption. But if it comes back with this very nonspecific pattern of spongiotic dermatitis with eosinophils, yeah, but it's not perfect, and you can miss stuff. So we don't want the biopsy to become a replacement for a thorough history and physical, but as an add-on tool, sure,
Great.
There's a lot of value.
That's very helpful.
So that's a great discussion. And now moving on to our next objective for today's talk is we talked about how we can use tools for achieving a better diagnosis, but I think a very important aspect of care for these patients is the patient perspective. How can we get an understanding of how the disease affects them? And one way that we can try to do that is by using measures of disease severity, right? And as you can see on the screen, most of the measures that we have listed there are physician measures, are things that we do when we're evaluating our patients, and most of them are being used in clinical trials. For example, the scoring in Atopic Dermatitis Index, or the EASI, the Eczema Area and Severity Index, or the Investigator's Global Assessment. And they give you a sense of how widespread the disease is, and the level of inflammation being the redness, the thickness of the skin, the level of excoriation. And then we also have POEM. So POEM is the patient-oriented eczema measure. So this is a measure for us to get a patient's perspective, right? Because this is something that the patient will be filling out. Other measures of quality of life that are important in clinic include the Dermatology Life Quality Index. And sometimes if we're in a hurry and we can't really do any of these assessments, you can use something as the numerical rating scale for pruritus, which is something on a scale from 0 to 10, and they can mark, which is a little bit more straightforward. Now, the American Academy of Dermatology, the guidelines really don't state actually that you should be using these types of measures in clinic, because some of them may not be very pragmatic if you're in a busy daily clinical practice. However, they do state that if practical in some cases, then you might consider incorporating something like POEM, just so that we can, again, get the patient's perspective. Now, the patient-oriented eczema measure, we'll move on. Is this something that you do in clinic? I mean, we have a questionnaire for our audience to see. It's a series of 7 questions that they can answer. So Jonathan, can you walk us through the POEM? Can you take us through it?
Sure. So the POEM, just for background, is actually considered to be sort of the best validated or the preferred patient-reported outcome measure for atopic dermatitis by the Harmonizing Outcome Measures in Eczema Group, which is this international consensus group. And it is a 7-question, short form or a paper form that can be used. There's electronic applications as well. And it assesses the frequency of 7 different symptoms over the past week. And even though it's not asking about the severity per se, we know that the frequency of symptoms highly correlates with severity. So it's a great proxy measure of severity. And what you see are the different columns in terms of the response options. So if they have, they answer no days, they would get scored as a 0. If they answer 1 to 2 days, they would get a 1. 3 to 4 days would be a 2. 5 to 6 would be 3. And then if they answered every day, they would get a score of 4 for that question. And then you just simply add them up. So you have a score of 0 to 28, where 0 is totally clear. 28 would be severe. And then there's a variety of different ranges in between that you can see on the slide. And this can provide a lot of important context. It's quick, it's easy, it takes about 2 minutes for the patient to complete. And I think we'll talk a little bit about some strategies that can be used and how this can be incorporated into clinical practice.
Okay, so before we move on, let's now watch a video which addresses this topic, and let's see how Dr. Hess tries to incorporate poem into his clinical practice. At least from our practice, when talking about the medical record, we probably use a different medical record in academics, and we create what's called a smart phrase, which becomes embedded into the medical record,
Sure.
and that's something that we're going to have our medical assistants start doing in clinic, because it takes burden away from the physician of having to do it, and it's something that they could do while they're being roomed, while they're waiting to see us, and I think it provides very valuable information.
With my EMR system, for example, I'm not really able to go in and customize it at this point. However, we could certainly have something printed out, have the patient fill it out in the room, and we could take a photograph on the EMR system uses iPads, and we could take a photograph of that and incorporate that right into the patient's chart. So I think there is a way to do it. I do know that some of the other assessment tools, the IGA, for example, the pruritus scale, some of these other assessment tools are already incorporated into my EMR, and I think that over time we could probably have the company maybe incorporate other tools, assessment tools that could be added.
But I think that's a great idea. In the meantime, if the electronic medical record doesn't have the capabilities to incorporate that, this is a freely available resource that we can print and we can use in our offices to get a better assessment of disease severity. I think that makes sense. So John, now we've heard the discussion with Dr. Hess. Can you talk to us a little bit as a primary care physician about whether or not there's a benefit to incorporate this POEM measure into your daily clinical practice? How would you go about doing it?
And there certainly is a piece of paper you can give patients. What I like is there is a free app, my eczema tracker, that someone can actually do POEM and bring in. We work in big groups, and it's nice to have scores that can translate from visit to visit if it's not you, just like mini mental status exams and other things that we use. So I think it's really helpful. It's not perfect, but I think it is a good thing that you can kind of see how are we doing therapy-wise. I
think that's great. And now that you mentioned therapy, can you talk to us a little bit about how you approach your treatment for patients with atopic dermatitis, treatment decisions in this population?
And I think it's a chronic disease, as I keep saying, and it is something that we need to be patient-centered. If we're going to be successful in taking care of anything, we need to talk about to our patients what's important to them. So patient preference might be, I prefer an ointment over a cream with regard to an emollient. Or a treatment vehicle. And then you're going to talk to them about what's important to them. And then this is a chronic disease. We'd like to keep it under control, so we need to talk about maintenance medicines, and we need to explain to them why that maintenance medicine is important, even when they don't have symptoms. And then we need to talk to them about handling a day that their disease is not doing so well. So much like we do with asthma, much like we would do with diabetes, we should have a little bit of a plan for an ordinary and an extraordinary day.
Sure. And Jonathan, can you talk to us a little bit about how you engage patients in their care? How do you bring them in to start the process of designing a treatment plan for them?
Sure. So, the first step really is education. There's a lot of things that patients can do that don't involve medications per se that can really improve their skin. Recognizing, proper moisturizing technique, the importance of moisturizing and using emollients after the shower or bath, and really trying to get a sense of the patient's preference. Working with their product preferences, but trying to give them guidance on what won't be irritating, avoiding known allergens, trying to minimize stress, as hard as that can be. And then, of course, ways of optimizing topical therapy and figuring out what would be the best strategy to incorporate into their busy lifestyle, and a variety of other environmental exposures that we can minimize.
And when speaking about topical treatments, John, can you talk to us a little bit about what are the topical treatment options that we have to offer these patients?
Absolutely, and we have a graph here from a paper from Dr. Eichenfeld and associates that really kind of runs through all the topical treatments. And remember, the majority of our patients are going to have mild disease. The majority of our patients are going to be treated from different products on that. The first and mainstay is emollients and moisturizers. Really gets an A rating. It really, regardless of your severity, everyone should be using some type of moisturizer. And then as we go down, topical steroids have been around for over 60 years. It's going to be the mainstay for a lot of folks. We need to be smart about what topical steroids we're using, where we're using it, and selecting it for the right patients. And we need to address some of that steroid phobia, which I think sometimes is so out of proportion for the medications we're going to be using. And then talking about the topical calcineurin inhibitors that have been around about 20 years. X number of years ago, they added a black box warning talking about cancers related to that, which to me doesn't really seem data driven, but I think that scares a lot of patients when we order those medications, which are steroid sparing, which have a lot of benefits. How do you guys address that cancer phobia with regard to that class of medicines?
No, I think that's a very important point, and I think it goes back to education. A lot of my patients who might be candidates for calcineurin inhibitors, I do have the discussion about how that there is a black box warning out there, what it means, and what it means for them in terms of their treatment. And the reason I do that is because I know that will probably increase their adherence to treatment, because if they go to pick up their prescription, they talk to a pharmacist who's doing his due diligence about telling them about the black box warning, then if I do not prepare the patient might get nervous and say, you know what, I'm not going to use that, and I'm not going to find out that they're not on treatment for the next couple of months until I see them again. So I don't know if you care to comment more on that.
Yeah, I mean, I completely agree. I think you want to get ahead of it. I think you want to take, even if it's an extra 30 seconds to a minute, just take that time, educate the patient, and say, look, you know, there's historical reasons why this black box warning came about, but it was a theoretical one, and all of the post-marketing data have been reassuring, and so we really don't have those concerns. Because if they don't hear about it, as you mentioned, and the pharmacist says, well, you're going to get cancer, well, they're never going to fill the script.
True.
So you need to explain to them that, yes, it's there, but we don't really reckon with it. We don't really think that's anything of importance.
And John, you mentioned previously about, you keep saying this is a chronic disease. You know, when we talk about treatments and topical treatments, there's different approaches, right? There's a reactive and a proactive approach. Can you talk to us a little bit about what that means?
Sure, and I think that reactive is you just wait till someone has a flare and you treat them. And if something only happened once a year, reactive is great, but this is a chronic disease that doesn't just happen once a year. And being proactive, whether it's just moisturizers every day, or sometimes it's a little beyond that. If you get a certain spot that tends to be bad, maybe you use your topical steroid once or twice a week, or your topical calcineurin inhibitors. One of the things, just also from that last table, the topical antihistamines are something that we are encouraged not to use. Doesn't show any evidence. So there's things that we should be using and things we shouldn't be using. And I think we're going to talk about some of the systemic things we shouldn't be using in a moment.
So when shifting focus, Jonathan, now to more systemic therapies, can you talk to us a little bit about what options we have out there?
Sure. So, well, the first thing is, what's not on this slide are systemic steroids. And as much as they're very commonly used, they're actually frowned upon by all of the treatment guidelines, because they're quick fixes and they're never enough for this chronic disease, period. So what has been shown to be effective, at least in some studies in atopic dermatitis, with off-label use, and that's a key consideration because none of these are approved by the FDA in the United States, the one that has the most efficacy is actually cyclosporin. And in the few head-to-head studies done, cyclosporin is actually more effective than systemic steroids. A key consideration is the dosing usually has to be higher in atopic dermatitis than it would be for psoriasis or other inflammatory disorders. Azathioprine and methotrexate are about comparable in terms of their efficacy, but not as good as cyclosporin. And then mycophenolate is the one that's often the least effective of those four agents, at least based on the literature and my own personal experience. All of them have variable efficacy. None of them have great long-term efficacy data. And then the big consideration for all of these is the side effect profile. I mean, for most clinicians, when they look at these, they kind of cringe. We have to check blood work. There's a lot of different issues we have to monitor. We're worried about long-term malignancy and infection risks. I mean, these are real considerations. And as much as some patients tolerate them fine, we have plenty of patients who have major complications here. So it is something that really highlights the need for more, better options.
That's great. And speaking of better options or more targeted treatment options, the past couple of years we've learned more about the pathogenesis of atopic dermatitis and the cytokines or proteins that are important. Can you talk to us a little bit about those key players that are going to become more important in terms of possible treatment options?
Sure. So as the schematic on the slide depicts, this has become a very complicated disorder in the sense that we have learned so much about the different inflammatory pathways involved. And what we don't yet know is just how much of a role each of these individual pathways plays or how dominant of an effect they play. But with all of these, the one pathway that seems to be implicated across all stages of disease, both acute and chronic, is the T helper 2 cytokine pathway, interleukin 4 and 13. Looks like the 13 is really the important one, but there may be a role for 4 on top of that. And then in chronic disease, we tend to think of it being more of an additional component of T helper 1, Th1 cytokines. But there's a variety of other cellular cells involved, other cytokine networks involved. And I think we're still learning a lot more about where all of these fit in the disease.
Okay, and speaking about cytokines, I think for the world of atopic dermatitis, the last couple of years, again, I reiterate, it's been exciting because the more we learn, the more we can develop newer treatment options for a disease that's really undertreated in a lot of cases. So can you talk to us a little bit about this new biologic called dupilumab that's out there? Can you take us over the clinical data?
Sure. So dupilumab is a monoclonal antibody that targets the interleukin 4 receptor alpha subunit. And this one actually forms 2 different complexes that are involved in the signaling of both IL-4 and IL-13. So as I just mentioned, it looks like IL-13 is the more important cytokine, but in this case, it takes out both. Okay. And these are really, the ones that have been most convincingly shown to be the major players in the disease. And so there were many, many studies that were done, but we can talk about on this slide the data from the Chronos study, which was a study that examined the effects of, or the efficacy and safety of dupilumab with topical corticosteroids compared to placebo with topical corticosteroids. And the efficacy endpoint here described is this eczema area and severity index with a 75% improvement. So that is a weighted average of both lesional severity and the surface area, the extent of the lesion. So it gives you sort of an overall assessment of the disease and saying how many patients got a 75% improvement in that endpoint. And already by week 2, there's a very clear separation between the dupilumab group and the placebo group. And that really continues out to around week 12 or 16 where you start to see that plateau. And what you can see is that it really sustains all the way out to week 52, where around 70% of patients are getting this 75% improvement of their overall lesions. Similarly, when we look at the improvement of itch, and in this study, the way it was assessed was looking at the worst itch in the past 24 hours and how many people had a 4-point improvement of itch, which is thought to be that minimal clinically important difference of itch. And what they found was that, again, already as early as day 2 or 3 in some of the post hoc analyses, but certainly already by week 1, clear separation of dupilumab compared to the placebo group, and that again plateaus at around week 8 to 12 and sustained all the way out to week 52. And a key thing is you notice some of that bumpiness, some of the little blips up and down on that. And that's because even though patients are having dramatic improvements of itch, they may still have a little, one day here or there where you get a little itch that comes up. And it's important not to think, the drug's not working anymore, it's losing efficacy. We see that. We see little ups and downs. But overall, dramatic improvements of itch over time.
And can you talk a little bit about, we've been talking about bringing in the patient perspectives, using something like the POEM score in clinic to get a better a sense of what our patients are going through. Can you describe or kind of summarize the data on dupilumab using the POEM score in the clinical trials?
Sure. So the way this was assessed was those patients who had a 4-point or more improvement of the POEM score, because other studies have shown that for POEM, the minimal important difference or minimal clinically important difference of POEM is 4 points. And what you see is that almost 80% of patients achieve this endpoint in the dupilumab group, both at week 16 and sustained out at week 52, compared to only about 25 or 37% in the placebo group. So from the patient side of the story, we're seeing really dramatic improvements in a very large subset of patients.
Okay. And John, as a primary care physician, right, we do have a new topical treatment option that's available for our patients. Can you talk to us a little bit about this option?
Crisaborole is our first new topical directed at atopic dermatitis medicine in about 20 years. It's a boron-based medicine. It is a PDE4 inhibitor. And it's an ointment, a twice-a-day ointment. in this particular slide, which has 2 different phase 3 clinical trials that Dr. Paller had done, and the patient population was mostly folks under the age of 18, what they looked at is people with mild to moderate atopic dermatitis, and did it drop them 2 points in severity. So either take you down to clear or almost clear, and about 1/3 of people reached that 2-point decrease. Now, if you look at that slide and you would say, well, vehicle did pretty well, but that's not unheard of in atopic dermatitis studies. If you look at tacrolimus, there was about a 20% improvement with vehicle. So this particular medicine had impact within about 8 days, had impact on pruritus, so met a lot of the metrics we'd really like to see for our patients. And if you look at this impact on quality of life, it certainly shows statistically significant improvement in quality of life, but this was not a poem-based assessment, right? So we want to just make sure that we're not completely looking at apples and oranges, but it did make people's lives better. So it's another tool in our box for our mild to moderate patients. Steroid sparing can be used any place on the body, age 2 and up.
And I think before we move on to our next video, I think an important point that I would kind of want to discuss with you, Jonathan, is, we talked about the more traditional systemic agents that are non-FDA approved, and someone may say, well, this patient has failed something like cyclosporine, which you just mentioned, it's one of the drugs that works the best. Why should I consider even dupilumab on this type of patient? Is that patient that severe that would just not respond to anything? Or can dupilumab still be an option in this patient population that is either intolerant of cyclosporine or has not been as responsive to cyclosporine?
Yeah, so the simple answer is yes, but we have some real data to justify that. So there is a study called the CAFE study, which looked at the efficacy and safety of dupilumab in patients who had either failed cyclosporine treatment, had inadequate efficacy, or couldn't tolerate it. So, it's important to understand this is not a head-to-head directly with cyclosporine, but these were patients who had already been exposed and didn't do very well. And still, you see actually dramatic improvements and really consistent efficacy in this study compared to all the other studies that were done across all comers. So what we see is that really it does work well in patients who have failed those systemic agents, and we can think of it, if we've already tried those conventional oral agents and gone, we certainly can consider it. I think it's fascinating because when you think about how broad and immunosuppressing some of those oral medications are, that if a patient fails those, to see such a dramatic response with this targeted approach, I think it's just a fascinating thing to consider and understand that.
Yeah, so I think that's been a great discussion so far. So now I want to move to our next video, which is we're going to try and see how these new medications have impacted our patients, right? And we're going to go to one of our videos with Dr. Hess. And I think it's a very exciting time in terms of the treatment for atopic dermatitis. We're seeing new therapies that are being approved. Just a couple of years ago, we had the first biologic approved dupilumab for the treatment of patients with atopic dermatitis 18 years of age or older. We have crisaborole ointment 2%, which is the first topical approved in more than probably 10 years for our patients.
It does not have some of the same side effects.
Doesn't have the same side effects. So have you used this in your clinical practice?
I have.
How have you seen that they change the way you treat patients? What sort of results have you seen?
I've used both of those medications that you mentioned. The crisaborole I do like. That's a new topical, as you mentioned, that's approved for mild to moderate atopic dermatitis in individuals 2 years of age and older. And I do use that medication, especially in younger folks who their parents may be very steroid phobic. They're afraid of the side effects of topical steroids. They don't like the idea of the black box warning with the calcineurin inhibitors. So it's a good option for those patients. I like that there is no limitations on duration of treatment with crisaborole or location. It can be used anywhere in the body. So I do find it to be helpful.
Okay.
And I do incorporate that not so much as a treatment for acute flares, but more as a maintenance treatment. I think it can be very helpful, although I do see some stinging and burning with that medication, especially when used on the face.
Okay.
Dupilumab, I think, has been an amazing addition to our armamentarium, the first biologic for atopic dermatitis, as you mentioned. and that's for moderate to severe disease, 18 years of age and older. And I think that has been life-changing for a number of my patients. Those who have failed other systemic therapies or couldn't tolerate them, it has been an unbelievable medication.
So I think those were some excellent comments from Dr. Hess. And as we round up the discussion on the treatment, I do want to make a point, and I think, and you alluded to this in the beginning of the discussion, how to bring the patient in during the shared decision-making process, right? We need to engage our patients. Education is going to be key, like in many other chronic diseases, and understanding patient preference is also going to be critical. And that there are tools out there that we can use. We do have the Eczema Action Plan. Jonathan, do you use something like this in your clinic? Is this something that you have tried to kind of incorporate to make it easier for our patients? Because we're giving them a lot of information, expecting them to do a lot of things in a very short amount of time.
Absolutely. I mean, I think, one is you really want to provide a combination of both, obviously, the verbal education and then the written education to support that. Probably only 20 or 30% of patients will actually retain everything we're saying, and especially because we're talking about such complicated regimen. The Eczema Action Plan has been a valuable addition in terms of education. I don't use some of the standard forms that are out there, but I build it into our after-visit summary, so it's all integrated into the electronic health record. But really something that walks them through all the different stages of their disease. But there are a variety of different Eczema Action Plans available. There's one available through the AAD, and it's something that I think is a really important component of educating patients.
Okay, so for our audience who's out there, just wanted to let you know that we do have a version of an Eczema Action Plan that's going to be available for you to download as a resource. So now we have covered a lot during this program, so now we're going to see how we can translate all this information and all this evidence into clinical practice. So we will do that with the case. So here we present JC, which is a 36-year-old man with an itchy red rash. He has had these symptoms on and off throughout his lifetime, and he feels that they have been getting progressively worse in recent years. The lesions are located in traditional areas for eczema, for example, the folds of the skin, but also widespread on the back and the extensor surfaces, which is not really a classical location as we've discussed. He's extremely itchy. We know that this is a burden for a patient population, and the impact of the disease has resulted in him not being able to work, has also had an impact on his career choices. Overall, JC is a pretty healthy patient. He doesn't really suffer from a lot of medical conditions. His review of systems is pretty negative. No B symptoms, unintended weight loss, fevers, no palpable lymph nodes. And again, the physical examination is characteristic of what we previously described. So when looking at this case, we do have the objective measures of disease severity as an example. So based on the scores and what we've had presented here in clinic, I would like to engage those that are participating in our program and ask them the question, what do you think is the level of disease severity in JC? How would you classify his disease severity? So please give us your response. You can choose between either mild, moderate, severe, very severe, or not sure. As soon as we get those responses, we will review them and we will let you know, and we'll discuss that further. So going back to our case, while we tabulate those responses, in terms of JC's treatment options, so far he has been treated with multiple topical steroids. He has used oral intramuscular steroid injections. Oral antihistamines have been prescribed numerous occasions for him. And in addition to that, he tries to adhere to a very gentle skincare regimen, meaning he will bathe daily, use a gentle soap, tries to avoid the irritants that he knows can irritate his skin even further, and he tries to use something like a bland emollient to moisturize the skin. So Jonathan, can you talk to us a little bit about what we may want to change in terms of JC's current treatment?
Sure. So I think that the first two points that you mentioned are ones that really can be improved, but particularly certainly the topical steroids. Of course, that's a mainstay of how we treat. But the repeated rounds of oral and intramuscular steroids really is a problem. As we mentioned, it's a quick fix. This is not going to be adequate for the long-term management of a chronic disease. And so that is something that you definitely need to think about, something that is a better tolerated long-term systemic option. The oral antihistamines is another biggie that can be improved upon because despite them being so commonly used, they're really discouraged in all of our treatment guidelines. Certainly the non-sedating antihistamines are thought to do pretty much nothing in the world of atopic dermatitis. They don't even sedate the patients to help them sleep. They don't help with the itch. The sedating antihistamines, they don't really do anything for the itch, as some believe, but they do help at least sedate the patient when there's a very strong sleep component. But of course, there's other ways of sedating and perhaps healthier, better ways of sedating patients. What we don't want to happen is we give a prescription for 25 milligrams or 10 milligrams of hydroxyzine, and then they end up on 100 milligrams 4 times a day, that there's real safety issues that come up. The last one, interestingly enough, is I think the one that many clinicians think would be the bad part, but actually is good, and that is the daily bathing. Some of the old dogma or old thought process was that patients should shower or bathe once a week or twice a week. But in fact, all the studies recently have shown that regular bathing is actually helpful. Not only is it not harmful, but it's actually helpful for the skin, provided that patients use a mild soap and moisturize, use those emollients after the shower or bath. They can really offset any drying effects. And so I think these are real opportunities for improvement.
Okay, so we're going to go to the responses now, and it looks like about 50% of our audience, with regards to the level of disease severity for JC, they picked that his level of disease severity was severe, which I think is something that we can agree on. Is that your assessment of this case?
Yeah.
And I also agree with what you mentioned about how bathing has always been kind of controversial, but the move is that right now that's not such an important issue. That's the frequent use of emollients, like you mentioned. That sets the stage for everything else. So going back to our case, we've discussed that this is a patient who has a level of disease severity as severe. Now, what would be our next step in management for this patient? So again, we would like to get the audience involved. So to our audience, you would see the question on your screen, on the screen, and the question is, what would be your next step in the management of JC? Is it to add something like crisaborole as a topical option? Maybe add something like cyclosporine or dupilumab? Would you continue with the current treatment regimen for 4 more weeks and then reassess? Or you're not sure how to proceed? So please take a moment to vote now, and we'll go over those responses in a minute. And while we do that, Jonathan, can you talk to us a little bit about this algorithm that we're seeing, and how do you approach your considerations for treatment in this patient population?
Yeah, so this is an algorithm that was developed by the International Eczema Council for how to determine when someone is systemic eligible for atopic dermatitis. And so the first question gets back to what we talked about. First of all, do they have atopic dermatitis? Do they have moderate to severe atopic dermatitis? Do we have that severity down correctly? And of course, POEM can be incorporated into some of that decision making. Has the alternative diagnoses or comorbid diagnoses like infections, other things, contact dermatitis been contemplated and ruled out? And then have you done all of that conservative approaches, education, irritant avoidance, regular moisturizing? But if you've done all of that and you've optimized topical therapy and you're still getting an inadequate response, then you have to think about, well, what do we step up to? Should it be phototherapy? Should it be an oral systemic agent? Should it be a biologic agent? And that's really where shared decision-making is going to come into play to help distinguish between those.
Yeah, and I think it's wonderful that you bring about the question or the comment of phototherapy, which is a treatment option that it is in the guidelines for treatment of atopic dermatitis. And it is suitable for some of our patients. It might work. But I'm finding issues about difficulty with access to the treatment. It's hard for them to find a center that's close to them that will allow the patient to go 2 to 3 times per week to get the treatment. There's also the issue about cost. The copays may sometimes be too high for our patients. It's something that they might not be able, to pay for. Is that something similar that you're seeing in clinic with your patients on phototherapy?
Yeah, I mean, it's a real challenge, especially with patients' work schedules and moms with babysitting issues. And then, frankly, for anyone living in rural America, there's just no place for them to go to get phototherapy. There aren't even centers for them to be seen at. So access is a major challenge.
Okay, and I think we have our audience response to the last question in terms of what would be our next treatment option for JC. And it looks like from the responses that about 24% would either choose treating the patient with something like cyclosporine or crisaborole, which is kind of interesting because you would think of cyclosporine being more moderate to severe versus crisaborole for a patient maybe with more mild disease or mild to moderate. About 36% of our audience selected dupilumab as their next treatment option. 2% would stay on the current treatment, and about 14% said they were not sure. So I want to take this opportunity to kind of discuss, maybe Dr. Silverberg, you can comment a little bit, Jonathan, about what you think would be the next step for a patient who's clearly not well controlled on a topical treatment regimen. Would you consider crisaborole a substitute for him at this point? Would you move into systemic treatment options for him to get a better or a quicker response or long-term response?
Yeah, so for a patient like this, I would think of crisaborole as being probably inappropriate. There's no reason why you couldn't use it for certain areas that are where you need steroid-sparing effects, but as the sole next step, it just would be inadequate. So, maybe if you use crisaborole, okay, but you would definitely need to at least contemplate the cyclosporin or the dupilumab, which are a whole different dimension of efficacy and really possible to see that real benefit in that severe patient population. And also keeping in mind, crisaborole is approved for mild to moderate. It's not even approved in that severe population, so it's a little off indication in that sense. And then the choice of cyclosporin versus dupilumab, it's going to come down to shared decision-making, background comorbidities, the long-term health, access issues, things like that. But at least I think those two would make the most sense. I would not want to continue the current treatment for 4 more weeks, and the reason being that topical steroids work pretty fast, and atopic dermatitis in general is a fairly responsive disease, right? As opposed to maybe hidradenitis or other disorders that can take a long time to heal. So when you get the right treatment, you usually see efficacy within a 3-4 week period. If you're not, pushing them to 8 weeks is not going to do you any much better. And so you really need to think early about stepping up to another treatment.
Okay, so seeing your patients early and trying to decide on a more maybe aggressive form of treatment that just prescribing another topical that may not just be enough for this particular patient.
I'll tell you, actually, for a patient like this, I'll have the conversation about cyclosporin or dupilumab on visit 1. I'll try the topicals first, but you have to understand with those most severe patients, there's a good chance topicals are going to fail, and you need to at least plant that seed, get that education going early so that they're emotionally prepared for the next steps.
What would be the next step? And so when speaking about some of these systemic medications, for example, in the case of biologic, like dupilumab, we know that these are medications that are expensive. We know that we are being increasingly in an environment where it's value-based, that we need to document that those interventions that may be costly in the beginning, whether or not there's a benefit to using them. So that will move us to our third learning objective for our audience, which is how can we document the utilization of clinical assessment tools and results into our clinical practice so that we can demonstrate that there is a value to using them. So before we do that, I would like to get a response from our audience about how often is it that they incorporate maybe some of these assessments in their clinic. So for our audience that's out there, the question is, how often do you document results of the POEM assessment when managing patients with atopic dermatitis? Never. You may do it sometimes, or you do it frequently, or you always do it in your very busy clinical practice. So please take a moment to vote now. And while we tabulate the results, John, I would like to shift the discussion to you about value-based health care, particularly for this disease.
Yeah. So value-based healthcare is the healthcare we now live in, and there's MACRA and MIPS and a lot of these things. And with each advancing year, CMS, which manages Medicare and Medicaid, kind of wants more for its dollar, and much more what we do is going to be tied to results. And that triple aim. So what do we really want ideally in healthcare? Well, we want good outcomes, a good patient experience. So that's efficacy plus safety. Really, that's what outcomes are. We want to improve the health of a population. JC is suffering. I mean, that is someone in our population who is suffering, and we talked about depression, we talked about suicide, we talked about a lot of things. If he gets a lot of steroids, he gets cataracts, he breaks his hip. A lot of things that if we took better care of him, maybe he's healthy and the population is healthier. And certainly we need to think about costs. So if there's lots of atopic dermatitis that I can adequately take care of in my office, maybe I'm not referring those patients on, but maybe I'm making sure that I'm following through on the steps. And even more enlightening is the quadruple aim, which takes that triple aim plus looks at improving the experience for the healthcare providers. And I think when we see people get better, it reinvigorates us for what we do each day.
question.
I think those are excellent points, John. And now, Jonathan, can you talk to us a little bit about, if we're considering, you mentioned, dupilumab, having this discussion very early on, a patient may say, well, I hear it's a biologic, it's a very expensive drug. Can you talk a little bit about the cost effectiveness of biologics for AD? What do we know so far about these interventions?
Yeah, so when we're thinking about that moderate to severe patient population, there's a lot going on in those patients. There's the direct costs involved in terms of their healthcare, outpatient visits, hospitalization, ER visits, things like that. There's the indirect costs related to lost work productivity and things like that. Of course, the medication costs that go along with that. And so all of a sudden, what some people just think of as being just eczema is an incredibly burdensome disease and one that can be quite costly to society. And so whenever we're looking at cost effectiveness, we always want to balance out the direct and indirect costs of the disease itself against the costs, obviously, of the utilization and of the medication, and how much quality of life improvement we get out of those medications. And so in the case of dupilumab for atopic dermatitis, while it is a costly medication, it is something that, when looking at all the cost effectiveness modeling, was found to actually be cost effective in the management of atopic dermatitis, particularly moderate to severe disease, and even more cost effective for severe disease than moderate disease, because there's so much more cost related to those patients. And actually to be as high value of an intervention as the biologics are in psoriasis that we're more familiar with over the years. And you can see in this table the modeling numbers for this ICER report that examined the cost effectiveness of atopic dermatitis, and found that the incremental costs per additional quality of life adjusted year is about $100,000, which is accepted norm in the US, that society is willing to pay about $100,000 to gain an additional quality of life adjusted year. But when you look, that's moderate to severe overall. When you look at severe overall, it's actually about $50,000. So it's actually very cost effective as these things go. So this is something that, when you're talking about that right patient, the really severe patients, this is a cost-effective medication.
Would be a good medication for them. So Jonathan, I think those have been very great and insightful comments, and we've covered a lot today. Before we end our program, I just want to ask a few key points that you would like to share with our audience about how you can maybe integrate what we discussed here today. So John, can we start with you?
So atopic dermatitis is a chronic disease, the most common chronic disease in childhood. There's some challenges in treatment and diagnosis, but like every other chronic disease we take care of in primary care, we should take it seriously and we should learn what to do. 80% of the time, we should be able to take care of mild to moderate disease in our offices. And I should be able to recognize that the disease is not going to get better, and there are patients that, if I'm not making them better, that I need to take advantage of resources in my community who can help those patients with that burden.
That's a great point. Jonathan, anything that you would like to add at this point?
Sure. So I think a few things we touched upon. One is really looking for that appropriate long-term treatment option in terms of balancing the clinical safety and efficacy, and taking that into account in terms of shared decision-making and patient characteristics, recognizing that there are new treatment options and even more coming, and that really there are things that we really can do to improve the quality of life of our patients. We talked about the integration of patient-reported outcomes, particularly the POEM. I think this is going to be an important part of demonstrating value of high-cost interventions, but really can help us step up our game to make sure that we are properly recognizing moderate to severe disease. And then, of course, education.
So again, Jonathan, thank you for being here today. I think we've had a very positive discussion that will ultimately benefit our patients. So I want to take a minute to remind our audience that we have created a very useful downloadable resource that includes the slides that we presented here today, as well as references and tools. I encourage you to please visit www.cmeoutfitters.com for a comprehensive list of clinical resources, outcome research news, additional educational activities for both providers and patients, and a whole lot more. So thank you again for joining us for the presentation portion of our program, and I ask you to stay with us for our After the Show segment. I hope that you will be able to integrate some of the strategies we discussed today in your care of patients with atopic dermatitis, and we will be back in 1 minute. Thank you. So welcome back, everyone. We have already received some questions, so let's just jump right in. So one of the questions from our audience, and I think this is an important question when you throw out the word biologic, right? Jonathan, can you review vaccinations for patients on dupilumab? What about herpes zoster in this population? So those are two questions. That may not be fair, but let's take the first one, vaccinations on dupilumab.
So keep in mind, we have to distinguish between children and adults, but we do have a vaccine study that was done in phase 2 that examined the efficacy of booster shots for, I think it was for Tdap and for one other one as well, and found no waning efficacy of the vaccine with the administration of dupilumab. So we're pretty comfortable that giving simultaneously the vaccine will not hurt the efficacy of the vaccine. The one outstanding question and what shows up in the package label is, well, what about live vaccines? And we don't really know the answer for sure, so it's hard to give an evidence-based recommendation. But in the adult population, there really aren't that many live vaccines anymore. Even the Zostavax has gone killed. So we have very few we do have to worry about. And I think if there's a scenario where a live vaccine needs to be used, you would simply want to deal with it on a case-by-case basis. Now, for children, it's a little different because there's more options that are going to be live or live attenuated vaccines. And there, we're going to learn more over time to understand how that impacts as well. But for right now, it's sort of a case-by-case situation. Personally, when dealing with things like flu shots and stuff like that, I don't even hold a dose of dupilumab. I've seen no issues, but of course that's anecdotal. With regard to the herpes zoster issue, that is something that was well studied or well described in terms of the efficacy, or I should say the safety outcomes of the clinical trial program. And there is no signal that we know of for herpes zoster, even in the elderly patient population. So that's obviously a very important consideration in those older patients where this can be a real concern.
And I agree with what you've said. I think important is the word biologic, right? A patient will come in saying, oh, I've heard there's this new biologic for atopic dermatitis, and they might think it has exactly the same risk as biologics for psoriasis, and that's not the case. And we should not dismiss that. We should take the time to discuss with our patient if we can. Like, yes, even though they fall under biologics, that risk for the vaccination, there are certain risks that are going to be different. Certainly, I do recommend trying to get the vaccines in before we start dupilumab. Again, I agree with you with the flu vaccine. I don't hold back on it. I think it's interesting once, we hope that this medication will be approved for a pediatric population, so that's going to raise a number of issues that we will undoubtedly have to deal with in the future. But for right now, it's primarily in adult patients. Do you have a comment, John, with respect to the vaccines?
The new recombinant zoster vaccine isn't live.
Yes.
And this really doesn't make people immunosuppressed. It's not chemotherapy. So even though that vaccine is not indicated right now for people who are immunocompromised, it probably wouldn't necessarily be that group. But I think the population we're all going to worry about this time of year is flu shots. So flu shots should be good.
There's a question from our audience about lymphoma risk, and I think their question is about lymphoma risk overall in our adult patient population, and is this or not a real concern? And if it is a concern, do we even bother counseling families about this? So I think this is an issue, and the rest part of the question is, do we need to do this to prevent malpractice? So that's another interesting point of discussion. I think this is primarily an issue more for the adult population, the lymphoma risk, and I think it goes back to, if you're thinking about CTCL, cutaneous T-cell lymphoma, the issue of whether or not you have the correct diagnosis, and CTCL is a very hard diagnosis to make. So I think asking about base symptoms, checking for lymph nodes, which again might happen in both, if the atopic dermatitis is very bad. Jonathan, can you talk a little bit about lymphoma risk as a comorbidity in this patient population?
Yeah, so this is actually one of the hardest epidemiology questions we have with respect to the comorbidities of atopic derm. So a lot of this really was only looked at because of the concerns around that black box warning for the topical calcineurin inhibitors. And so everyone started looking, well, is there really a lymphoma risk or not? And what they found was that seemingly not with the calcineurin inhibitors, but if anything, for very severe atopic dermatitis cases who are using high-potency topical steroids. So that opened up a whole new world of understanding, well, maybe atopic dermatitis in of itself could be associated with either T-cell lymphoma or other types of lymphomas. We're not talking about a massive effect size here.
Yes.
We're talking about a fairly small effect size, and there's really a lot of uncertainty about how much of it is a medication thing, how much of it is really related to atopic dermatitis, how much of it is related to some other confounding factors. So I don't think we need to worry about counseling all patients about lymphoma in a general sense. Again, nothing substitutes for a thorough history and physical exam and regular follow-up, and if you're doing that, you're going to pick up on a lot anyway. Regarding the black box warning issues for the calcineurin inhibitors, that's a little bit of a different discussion. And from what we know right now and around the safety of this, I'm not sure if there's really any malpractice issues, but as we talked about earlier, it's a good idea to get ahead of that and talk to the patients about it anyway, because at this point, all it is a theoretical risk. The data have not shown any significant signals.
I agree. And I think it's important to kind of reiterate that's there, unfortunately there is a black box warning that we need to address, but that, again, patient education is going to be key. Do you have any comments?
But oral patients who are on oral tacrolimus for solid organ transplant
Which is
is
different.
not the same as
Of course.
topical tacrolimus, which we really don't absorb a whole lot.
Exactly.
So I think it's the same name drug, but I think it's infinitely
which can
different.
be confusing, but it's important to make that distinction that it doesn't apply to this particular patient population. And perhaps maybe in our patients with mild to moderate disease, where we would be maybe using this more consistently, it might not even be an issue that you need to concern yourself with and have this precious time dedicated to that discussion when you need to probably address other points that are maybe more important.
Sure.
And then I remember when we were talking about treatment, you mentioned about emollient use and bathing and things like that. And John, we have a question from our audience stating, they were taught by their mentors that bathing actually exacerbates atopic dermatitis and its symptoms. And it's something that we probably run into at some point during our training. And that's pretty much the nature of medicine. It changes with time. Can you talk about bathing, and as a primary care physician, what do you tell your patients?
So I remember being a young person and someone kind of talking about not putting kids in the bath, and you always thought that was some mentor who didn't have children, right? So certainly we want our kids to bathe. I don't think we're going to have them soak in the tub for kind of 2 hours, as sometimes kids would want to do, but I think getting them bathed is important. Bleach baths, I think, is something that's been very kind of fascinating, is just how effective it really can be, especially for people who get recurrent staphylococcal skin infections and things like that. So I think bathing is probably a good thing, and I think we have an appropriate population who putting a little Clorox or household bleach in the bathtub to kind of reach that chlorine concentration very akin to a swimming pool can be really helpful for our kids. It benefits where the water touches. It doesn't help, for face and head, but I think bathing's a good thing. So all that's old is new again, right?
And you raised the discussion on bleach baths, so I want to take that opportunity because we didn't go, through this in the show. Jonathan, you don't work on this. Can you talk a little bit about, first of all, what's your approach with like bleach baths, for example, and what's the evidence behind it?
Sure. So I think it's great that you brought it up because it ties into the whole bathing story as well. So bleach baths were actually developed by my chair, Amy Paller, years ago. It was an interesting study done where they looked at bleach baths plus topical chlorimethrin plus 2 weeks of an oral antibiotic compared to a group that had all those other interventions without the bleach. So even there, it was an interesting sort of compound intervention. And they found some mixed results, but overall efficacy, significant efficacy on points for certain things. There are 4 studies done now on bleach baths, and actually very mixed results. Yeah. And we recently published a meta-analysis on this showing that what's fascinating was the bleach baths worked. They showed significant efficacy, but no better than just a good old-fashioned water bath. Now, it may be different when you're dealing with infections, and I fully agree. Yeah. When you're worried about staph and things like that, that's a whole different consideration. But that meta-analysis showed very clearly just a good water bath alone was effective in that meta-analytic approach. So, I counter this all the time with clinicians who are were told once upon a time not to bathe. And I think part of it is for something that has been coined the Hannafin paradox of bathing. I don't think he coined that himself, but others have coined that. And the idea is that if a patient takes a shower or bath and they do not moisturize afterwards, it's going to dry them out. And it can actually be very harsh on the skin. But if they take that shower bath and they moisturize immediately afterwards, and they can seal that moisture in, not only is it not harmful, but it actually has that beneficial effect. This concept of prehydration before putting on medications or putting on emollients. And so I think this is something that really all of the evidence shows. We can be very comfortable making this recommendation of daily bathing, provided that we present the next step, which is but moisturize, put on those emollients afterwards.
And when speaking about emollients, I think this may be a question from our audience is, there's so many emollients out there. You could go to the pharmacy and spend hours picking and choosing. And a lot of patients come to me, well, which is the best one? Which is the one that I should use? And usually my honest answer is, the one you like and the one you'll use, right?
Yeah.
I can try to impose which one I think is best, but there's a lot of questions about, is it a ceramide containing, alpha hydroxy? Like, it just goes into all these details. Do you want to comment on emollient use and what we should recommend or be recommending?
So I completely agree. I mean, here's where patient preference is so important. From an efficacy and a cost standpoint, good old-fashioned petroleum jelly does an amazing job. But man, that's greasy, and it's not for everyone. So there's where the elegance of creams and lotions come in, but the cost can grow exponentially. The tolerability can be issues because then all of a sudden there's more preservatives in there, and now they're adding some fragrances and other things. So there's a tolerability issue that comes up as well. So I have the same conversation. I'll say, look, if you're going on efficacy, good old petroleum jelly, but what that balance of what you like putting on your skin, what you're going to actually use, and what's not going to break the bank.
And what's your perspective as a primary care physician?
I think the same thing. And also, the next thing down the road isn't going to necessarily work better if you don't have emollients as kind of part of that. So I think of what suits someone's tastes, what someone likes, what someone can afford. But spending 10 times as much on something isn't going to work 10 times as well. And a lot of these are people's kids, and they'll do anything. So sometimes you have to have a little bit of that paternal, maternal thing to say, don't spend all your money on this, but find something you like that's affordable and use it.
I think sometimes, patients take almost too literally our recommendations about things, because sometimes we don't realize how much it's going to cost them, and they may not realize that we're okay with an alternative or a swap.
Whichever it is.
And then it'll come back and they've spent hundreds, if not thousands of dollars on these things, and you cringe. You're like, well, why'd you spend so much? Because you told me to use it, so I used it. So I think we really need to factor cost into how we recommend over-the-counter products to our patients.
Buy in bulk.
Buy in bulk. So we have a question here about comorbidities, again, switching topics a little bit in atopic dermatitis. We've seen how cardiovascular disease is a comorbidity that we've seen in patients with psoriasis. It raises the question of, should we be treating those patients early to prevent the onset of cardiovascular disease? Can you talk a little bit about, specifically, Jonathan, in your case, cardiovascular and perhaps things like depression, about those types of comorbidities in this adult patient population?
Sure. So this is an area near and dear to my heart. We've done a lot of work in this, looking at the associations, and multiple studies now have shown, either cross-sectionally or longitudinal studies, associations with either cardiovascular risk factors, obesity, hypertension, or just a sedentary activity, early smoking, alcohol consumption, and then cardiovascular disease and events. Now, there's some mixed results, and it's like anything else. You need multiple studies to show this, but it looks like this association has really been confirmed now. And we don't know the answer to this question, though. Does treating the atopic dermatitis really prevent? Logically, we would think it does, but we have a whole world of research that still needs to be done to show that. But I think it's something that, we're counseling patients anyway. Like, if a patient is obese, if a patient is a smoker, this is a no-brainer that we should be mentioning to them to quit this. The fact that they may also improve their atopic dermatitis or improve cardiovascular risk down the road, is icing on the cake. But these are things that, these are simple recommendations for us to accept upon ourselves.
And when speaking about depression or anxiety, as a primary care physician, treating the whole patient, I'm not a primary care physician, but one of the questions I go into my discussion with patients is, are you depressed or anxious because of your disease? And you'd be surprised at the number of patients who say, well, I'm not really depressed, but I'm anxious because I don't know where my next flare is going to be or where I'm going to be when that happens. Will it be at my graduation or my wedding? And that can cause a lot of distress. Is this something that you run
And
to in
absolutely,
clinic?
people isolate because they're worried that they're going to have a flare. They don't go to things and things like that. And we all were trainees in medicine once upon a time and didn't get enough sleep, right? And maybe we trade that as we become parents. But you know, if you're someone who has a disease it's impacting your sleep every night, it's really hard for that not to start working on your wellness. And if we can actually fix their disease enough that they're sleeping better at night, everything looks a little bit better. So that they are Venn diagrams that overlap tremendously. In the article this week in JAMA Dermatology that showed a meta-analysis of increased suicide attempts, increased suicidal ideation in folks who have atopic dermatitis, and that 30 to 40%, that's real. Over 300,000 patients looked at in these meta-analyses. So it's something that should be part of our global care, patient-centered care of this chronic disease.
And to finish our discussion on comorbidities, there is a question from our audience about what is the prevalence of contact dermatitis in this population, and that is a very hard question to answer,
Yes,
right,
it is.
Jonathan? Any comments on that?
Yeah, I mean, it really depends on the cohort and the studies done. You know, keeping in mind that most of the studies are done in patch testing centers where the pretest probability has gone up dramatically because why were they referred in the first place? So we don't really have data on people just randomly tested in the atopic derm world to know. And it's very hard to read patch tests in patients with atopic dermatitis. You get false positives and false negatives all the time. So suffice it to say, it's common. That's about all we can go with. And I think you want to recognize certain key scenarios to consider it. One is, as you mentioned earlier, localized distributions. Like if there's a strong component on hands or eyelids, face. Even outside of atopic dermatitis, if we saw that, we'd be thinking possible contact derm. If they're really refractory to therapy, or there's a really severe case where we're at that point where we're about to step up to a systemic agent, it's probably worthwhile to get them patch tested, find out, is there a component of contact dermatitis that's making this more severe or refractory, and then maybe we don't have to put them on a systemic agent long term.
Okay, moving on to the treatments, and we have about 4 minutes left, so we're going to try and pick a few questions before we have to end the program. There's a question here about the dosing on dupilumab, whether or not you can use one injection and then two. The FDA approval recommendation is a 2-injection loading dose, and then it's an injection every 2 weeks afterwards. And that's usually what I recommend to my patients. I try not to go off script in terms of the injection, first of all, because of insurance, and also because we don't have the evidence whether or not those types of changes in the injection schedule will actually work. Our patients may have needle phobia, so one of the strategies I do is I bring them back to my office, not leave them alone to do the first injections. I have them come in, I sit with them, and our staff takes them through the process of this is how you would inject, and we make sure that they're injecting properly. Is this something of an issue, the needle phobia that you may be seeing in clinic, that a patient may want to take a step back and not try the medication because of this?
I mean, at this point, not that much, only because there's nothing else out there that's approved with this level of efficacy and safety. That may change with an emerging landscape of options, but for now, yes, patients are not fond of it, but they experience so much pain already in their atopic dermatitis that once they get through it, it's not a big deal. I agree, it's worth making sure that someone has eyes on and gives them the proper education about the injections, but usually it's not a big deal. To the issue of going with a single dose, they just won't get the efficacy as fast. It may delay things by weeks or even months. So you really want to get into that steady state of dosing early on, and that's what the loading dose accomplishes. So.
And are there potential, speaking of dupilumab, drug-drug interactions that we need to focus on this population? I mean, we are treating patients who are older, have more chronic diseases. There are a fair number of medications. What would you counsel or what you recommend in terms of drug-drug interactions?
So not really, but in the package insert, there's technically language there, as is found in all the biologic inserts, about interactions with cytochrome P450, because cytokines can modulate cytochrome P450. That's a very broad, vague concept, right? It's nothing specific to dupilumab. So basically, anyone who's on warfarin, maybe you'll see some blip, but they're getting their INRs checked anyway, and most of them are getting switched over to alternative anticoagulants now over time. And then for things like cyclosporin, I guess if they're on high doses simultaneously, it could be an issue. We just haven't seen it in the real world. So I really don't counsel very much unless the patient's on warfarin or one of those known problem drugs going through this P450 pathway.
Okay, and very briefly, we have a comment from our audience about, again, topical antihistamine use. And can you comment again on that and how that is?
So the recommendation from the Eichenfeld paper gave it a B recommendation against using it. So there's strong evidence not to use topical antihistamines. Sometimes it helps people because there's a vehicle in it.
A vehicle, yeah.
So maybe more of the vehicle and less of the antihistamine.
And there's one caveat there, which is topical doxepin, which has been shown to have some benefit, but that may not be because of antihistamines. That's because it touches many other pathways, and it also hasn't been replicated across studies. So and it's hard to get compounded. Right. It's really expensive. So there's really not much of a role for that in treatment.
Well, thank you both again. I would like to thank John and Jonathan. It's been a very wonderful program, and our audience for joining us today. Thank you as well to CME Outfitters for your assistance in developing this educational activity. And audience, again, a very heartfelt thank you for those who took out the time to just be with us on your very busy day to learn ways to improve the care of your patients with atopic dermatitis. Again, I'm Dr. Selma Chiesa, and I hope you are able to incorporate some of the recommendations we provided for you into your practice to improve the care of your patients with atopic dermatitis. Thank you, and have a good rest of the day.